All right. Well, welcome everyone. It is definitely my pleasure to introduce Dr. John Batsis. He is known to many, or most of us probably here today. So I'm not going to go into a whole lot of detail, but Dr. Batsis is a friend to our center, has done a lot of work with us in the overlapping spheres of aging and arthritis and function. He is a geriatrician and has been working at UNC for, I think, quite some time now. He has research that focuses on various areas related to aging and function, as I mentioned. That includes things like the relationship of obesity and sarcopenia to function and other outcomes, multi-component interventions that he has a newly funded, I believe, R1 that maybe he'll be talking about today, but dealing with some novel intervention strategies, and then also novel technologies, which he'll certainly talk about today. So we're looking forward to what you have to talk with us about, Dr. Batsis, and I know we'll leave some time at the end for questions. So title of Dr. Batsis' presentation today is Technology Development in the Aging Sphere. So whenever you are ready.
Thanks, Kelly. Really appreciate the kind introduction, and always nice to see friendly and familiar faces here at TARC. So, as Kelly mentioned, my research portfolio really has a lot to do with physical function and aging. And I always like to say that the technology component of it really sprung out a number of years ago, and it was kind of a little bit my pet project, so to speak, that has now infiltrated in multiple areas of my research. So today's presentation is really going to be less about obesity and sarcopenia, but more about technology. And I'm going to give a use example a little bit later on as well. So let me get this going. Okay, funding sources. Just putting in here, so full disclosure, I will be speaking about a product that we have developed as part of one of my career development award. And we have a small startup company, Synchro Health, which will be discussing some of the data that is currently available and 2 patents that have come out of it. So I just want in full disclosure about that. So overviews, really want to talk briefly about healthy aging and why it's important. Talk about some technology used in older adults and some of the nuances thereof, and give a little bit of an evidence base. One thing that I continually drives me a little bit bananas when I see summary statements saying that older adults can't use technology. That really kind of, there's a lot of bias in that, and I'll provide some data to demonstrate otherwise. And then really kind of switch gears a little bit in terms of talking about how technology really should be designed for the older adult, and then use example with BandPass, which is the product that we've developed and the system that we've developed towards the end. Okay, so Kelly mentioned I'm a geriatrician by training. A couple of glimpses from the front line where Mr. Smith comes to my office and he says, I want to preserve my health. I worry about my physical function and quality of life. And importantly, he's realized, and have others, that COVID-19 has really transformed how older adults interact with technology. So before we kind of dive into the technology component, I think it's important just to talk about healthy aging. This is a figure that from an article that we published in the Journal of American Geriatric Society a couple of years ago that talked about healthy aging in the context of COVID-19. And these really align with a lot of the health promotion paradigms that we know can promote healthy aging, managing chronic conditions, optimizing cognitive health, physical health, mental health, and importantly, social engagement. And really, in my mind, technology can really help each and every one of these. But why is this important? Well, I'd be remiss as a geriatrician not to talk about disability as a harbinger of aging. If you live long enough, you will develop an impairment of one of your basic activities of daily living. And this is really a seminal study published a number of years ago, but really is a telltale in the sense that you live long enough, you will have an impairment in your ability to walk, get out of bed, dress yourself, feed yourself, toilet yourself, and the like. But what we know is if we can focus on healthy aging, that it can compress the risk of disability and the number of years that you have left, and the proportion of those years being either healthy and without disability versus the proportion of years having disability. So this is, again, a lot of numbers here, but the point of this study, this was another really seminal study in geriatrics, which really used the cardiovascular health study, almost 26 years worth of data, that looked at individuals and found that poor healthy eating habits, obesity, and physical inactivity were all three major predictors that actually increase one's remaining lifespan with the number of years of actually having a increased risk of disability. So if we have good healthy eating habits, are not classified as having obesity, and are physically active, whatever remaining amount of time you have left, that the number of years, the proportion of the number of years left will be actually much lower, and you'll have better quality life and years of disability, disability-free years than those who have the contrary. And there have been a number of studies. I'm not going to go through them just for the interest of time and the scope of this talk. But I thought this was another interesting one, which really, again, looked at a 20 years perspective and free of major disease at baseline at middle age. And they looked at 9 factors. What they found is that there was incremental increase of the risk of developing disability and over time, with increased risk of smoking, lack of physical activity, alcohol use, obesity, and social support being the 5 major risk factors. So one of the things, again, a lot of my early life was really fully in clinical care. So I was trying to figure out, how do we help our older adults? And this was, in the a decade plus ago, technology wasn't as rampant and as ubiquitous as it is now. So really thinking about, how can we use technology to kind of maximize healthy aging. Before I go on, though, I think it's really important that we talk about some definitions. And this is often a very major source of confusion. In fact, I was on a call yesterday with a program officer, and we were really on different pages. I was talking about telemedicine. She was talking about telehealth. We were meaning different things. So what I want to do here is just set the ground straight, at least for this presentation, to kind of get everybody on a footing. Telehealth is an umbrella term. It includes pretty much everything, including what we're doing now, two-way, real-time interactive communication. It can include education. It can include digital information. It can include our lovely MyChart messaging, versus telemedicine, which is really about two-way video-based communication. Remote patient monitoring is another subset of telehealth, and this includes remote-based devices that collect data often outside of a healthcare setting, and then brought to the attention of either the patient or provider. And this is another way of looking at it, is really telehealth being kind of like an umbrella term of all these entities. So there's a lot, and this is just one inkling of what we think about in a healthcare system, in terms of how we can obtain digital type of data. We know about home blood pressure monitors. We know about weights. We have ECGs now that can assess atrial fibrillation in the home-based setting. A lot of these mechanisms are Bluetooth enabled, and then they can interact with different systems. And the challenge really is how do you get it from the patient to the healthcare entity? And that's really a big gap in the science. But what has really advanced the use of technology over the course of the last decade or so is broadband access. When I started in thinking about technology, the question that arose time and time again, and for those of you that don't know, I was previously up at Dartmouth in the northeast, so a very rural area where broadband was difficult to come by. Broadband has changed considerably. the access to broadband has changed, and even in rural areas. And you can see just the map. I wasn't able to get a exactly the same map, but you can see blue indicates broadband, high-speed availability of broadband access. It's completely different in December 2022 data versus 2014 data. So I think the argument, while there are certain areas that don't have broadband access, the majority of adults in general, populations, have access to broadband, had broadband access. I actually, for a summary statement, I needed to find some North Carolina data, and 93.7% of North Carolinians have access to high-speed broadband, fixed broadband access. So this is a little bit older meaning less than 2 years, but in the technology sphere, things kind of progress pretty quickly. But what I liked about this study is really showing the trends over the last decade. And the indicator, the graph on the left, and the line, the green line here, is 65 and up. And you can see the proportion of older adults using technology in, say, 2012 was 13%. This is a Pew Research Organization survey, and it's really skyrocketed up to 61%. And this was really right at the beginning of the pandemic. So a lot of folks actually are using smartphones. A lot of folks have tablets or computers. And what we know is that the proportion of older adults is actually skyrocketing in terms of using technology. Again, it's anticipated that, 5 years ago, this was really low. It's higher 5 years later, and it'll be even higher 5 years later, 5 years down the road. One of the things that's really important to kind of be mindful is, irrespectively of age, there are still disparities of care in terms of access and use of both smartphone and home broadband technologies, both rural, economically, and by education status, in terms of using the technology. And while we saw a huge rise in the use of telemedicine use by age, income status in rural, urban, there were still disparities of care observed here. So I'm going to switch a little bit gears, just to share a little bit of the work that kind of I had done a number of years ago. And this was in the kind of about 2014, 2015 years, where broadband access was not rampantly available, and older adults really were just starting to use technology. We had conducted some qualitative work, which really looked at, we tried to triangulate by engaging clinicians, community aging leaders, and patient participants. And what we found is that all of the above felt that technology could be helpful in different types of technology. Sensors, fitness devices can help with knowledge, tracking, and provide insight, motivation, and accountability. Really, all key factors to elicit behavioral change to improve health. But there were a number of barriers that were specific to rural older adults. Importantly, transportation, big issue. Throw a snowstorm in there, becomes even bigger issue. But older adults were keen. They were keen, and they continue to be keen on using and wanting to learn how to use technology. Clinicians at that point felt that they were much more skeptical about older adults using technology, but everybody agreed that there wasn't a one-size-fits-all, that one device would be appropriate for all individuals, and that certain individuals, you need to be able to kind of identify a given individual's need and given individual's desire to use a given technology to be able to engage in self-monitoring. So satisfaction in using telehealth modalities is high, even in older adults. This was a Press-Ganey satisfaction survey in New York City, published a couple of years ago, and then a subsequent systematic review demonstrated, 47 studies, demonstrated really mostly positive or equivocal insights in terms of telehealth use in older adults. So I think the evidence is really there that older adults are willing to use technology, and irrespective of the type, but it needs to be individualized in terms of the use thereof. This is a schematic that I was part of. It was a part of the geriatric cardiology section of the American College of Cardiology. It was a consensus statement on gerotechnology, so the use of technology to engage older adults in improving their cardiovascular health. And I like this schematic because it really sets the stage of when you think about use of technology in older adults, you need to identify what are the goals, why are you using it. Then you need to assess barriers to using such technology. And then the hope is, if you're using a commercial technology, can you optimize it to match the technology, the barriers to the technology needs of the patient? Or do you need to design a new system, or have someone design a new system that accounts for that? And then providing support. We know that individuals, particularly older adults, often rely on their caregivers, on their children, or importantly, their grandchildren sometimes, to be able to help them navigate some of this technology. But once they learn it, it's a learnability issue. Once they're over that learnability barrier, then often it's smooth sailing from there. And we know that use of technology and telehealth modalities, this is one that was managing chronic conditions. And again, I'm just kind of taking piecemeal examples because there's plenty of data to suggest it does work. So this was a home-based care manager and homebound older adults. It demonstrated improved medication adherence and quality of life via both telephone and video messaging. Internet based self-management is a different modality. And this was one that was supplemented with telephone nurse visits in primary care. Again, demonstrated a reduction in hospitalization or death and a reduction in the first-time hospitalizations. How about physical activity? We all know about all the remote monitors and Fitbits and the like. And what we know in the data is there that the more steps you take per day, the lower risk of mortality and improved risk of physical function. It's thought that a combination of web-based, text-based, and telephone-based may be more efficacious than individual interventions, and it's really the sum of the parts is greater than the whole. We had done a number of pilot studies early on using remote monitoring, and this was a weight loss intervention in older adults with obesity. It was 12-week intervention, which it was a dietitian and physical therapy based interventions augmented with Fitbit home-based monitoring. And in this, it wasn't a randomized trial, so we did not compare it without the remote monitoring, but we did find that high satisfaction, high acceptability, and patients themselves qualitatively felt that it facilitated their activity and weight loss. Subsequent to that, this was the era where in the mid 2010s, where telemedicine and two-way video conferencing started to gain some traction. But from a clinical care standpoint, there were a huge number of barriers regarding licensing and site of origination and the like. What I wanted to do with our team at that point was to systematically look at the literature and see whether or not, were older adults using telemedicine, and what were the outcomes of it. So it was really to look at efficacy and effectiveness of telemedicine use. So this was a systematic review. We found 17 studies. We qualitatively summarized them. And we found that older adults really liked using it. It was effective in improving outcomes, and they found it was easy to use. So that was actually really promising and really provided some foundational data for another pilot study that I had done as part of my career development award, which really this data really sprung board to my current R01, which really was to do a telemedicine-based obesity weight loss intervention in older adults. And this was a 6-month study of 53 individuals with multiple chronic conditions. And we were able to successfully deliver the intervention using two-way video conferencing telemedicine in older adults, and found, reasonable weight loss and importantly improvements in physical function represented by changes in sit-to-stand repetitions and 6-minute walk tests and subjective measures of late life function and disability measures. We also augmented this intervention using Fitbit, and you can see here that in our 44 completers, we're looking at pre-post, that individuals actually were using the Fitbit quite regularly. There are other important uses of telehealth modalities. The Europeans often use ICT technologies, and I'm blanking on its informational communication technologies. And these are defined as robots, wearables, smart homes. They've done a lot of work in this. And this is where really transdisciplinary team science comes into play, where you have a clinician may have an idea, or a computer scientist or engineer may have an idea, but you really need to have that bi-directional discussions, because otherwise you're going to run problems with usability. There was one systematic review that did not find any significant changes, but what we know is that these can be helpful, and I see this in my clinical practice, where, for instance, the talking cat in patients with dementia. It provides an opportunity. I don't know if you all have seen it. It looks like a cat. It feels like a cat. It meows like a cat. And older adults actually are hugging it like a doll, and it actually can interact with patients with dementia in a soft-spoken kind of way. And it actually has been shown to reduce one's behavioral disturbances. We have done, since my transition here to UNC a few years back, I've been working collaboratively with a computer scientist who has an interest in voice patterns and Amazon Alexas. And these, again, are becoming more ubiquitous devices in the sense that a number of even older adults have it. I think the latest statistic that I saw was like 60% of older adult households have an Amazon Alexa. We have actually been able to create algorithms using voice patterns from Amazon Alexa, and with a diagnostic accuracy of identifying, is there some type of cognitive dysfunction with an accuracy of 86%. And we're using deep learning, applying deep learning to such voice recognition. So it's really kind of exciting stuff, and an untapped resource that can be potentially used in other domains. But there are privacy issues when we think about not only voice, Amazon Alexa and voice assistant systems, but technology in general. We actually, one of Hilary Spangler, who is a chief resident and current geriatrics fellow, this has actually just been recently accepted. We did a survey, and we found that older adults actually were more trusting of technology-based endeavors than the younger adults. Maybe younger adults have more experience and have had more exposure, but this is something just kind of it was a little bit of a paradox. We had expected the flip to that. So again, more further research is needed. Remote patient monitoring. Many commercial systems are available. The problem here is not only insurers are slow to pay, but the integration into electronic medical records is terribly lacking at this stage. I don't know about you, from a clinician standpoint, I love data. I love seeing data. But I don't want to see it as a clinician. I don't have time to do that. So I think there's a huge gap between the systems that are available and then actually being able to do something actionable within clinical care. it's improving, but this is where our informatics-based endeavors are really critically important to kind of, really narrow that gap. I'm going to skip this for a minute here. Okay. So let me switch gears a little bit in terms of thinking about why should we care about tailoring technology to older adults? And these are some barriers that I've already kind of discussed a little bit, but in terms of incorporating these into healthcare, there are engineering barriers. So you have a product, it looks like it works as a prototype, and then it doesn't, and then you're not getting the data that you want. The translation into clinical care doesn't occur. And then human barriers, and particularly for older adults, they have physical and cognitive limitations. We've talked about privacy. I have family members that have technology anxiety. They're like, do I really need to see another device? And then accessibility issues as well. Here's one of the things that's really important anytime when you think about, does a technology work? And I think a major limitation in the science is that many studies have a limited sample size and are tested in younger cohorts without comorbidity, and we need more studies with those with lower digital literacy, and that's a big gap in the science here. And unfortunately, the diversity of the samples existing are focused really more on white and white women versus non-white and males. And many of the interventions actually are short-lived, 10 to 12 weeks. So we're not looking at the sustainability of the effects. So this is something when you're thinking about designing telehealth-based interventions, you really need to think more intermediate to long term. Anyone can use a device for a given period of time, but it's really, and this is one of the challenges, a lot of startups and a lot of manufacturers and researchers trying to get these out in a quick manner are conducting studies that are really short-lived. So a lot of smart people, and I've worked with a lot of smart people, and particularly when I'm in a room, I always love when I'm in a room with computer scientists and engineers, and they're having their own discussions, and I'm the clinician, which at this stage, I seem to understand some of the verbiage, but there's a huge gap between getting a device from the lab to the field. And I often share this anecdote when I give talks. I was at an engineering conference a couple of years ago, and you have folks that are presenting their device, presenting the data on a younger cohort, and saying we have all this data, but it's the real world field-based in the wild, as we like to call it, in the CS world, that is missing. And that really we need to kind of move away from lab-based to field-based endeavors. So how do you solve a clinical need like this? So going back to Mr. Smith, what we were thinking about was really thinking about muscle and function. And as we know that as one ages, the amount of muscle decreases, amount of muscle mass decreases, the muscle strength decreases. There's fat infiltration within muscle, the muscle architecture. So sarcopenia is the loss of muscle mass, strength, and function with time over time, and then myosteatosis is really the fat infiltration in muscle tissue. So we were wondering, how do we engage older adults in kind of improving their strength at home, recognizing that only 40% of older adults are compliant with their home-based exercise programs. And we really developed a collaborative team. And this is right towards the tail end before I transitioned to UNC up at Dartmouth, consisting of computer scientists, engineers, data scientists, and myself as a clinician. So we were really wanted to think about how do we design a technology like this? And I think it's really important just to put it into perspective. And technology is costly. And for instance, we were thinking, well, can we create a given app a commercial grade app to improve health really is expensive. And when you see this is I love this diagram because it really shares that the average cost of a given app is about $270,000. So if you're going to be pouring in resources and getting individuals to either give you money through funding or investors otherwise, how do you design a system so it doesn't end up in the closet? And I know that sounds very kind of colloquial, but it really is the true thing. We say end up in the closet, end up on the shelf. The majority of devices and apps and systems don't make it to market, and then they're just there and they're not used. So we really need to think about designing a system using user-centered design principles. And when we mention this, what is it? It's really not only what it looks like, is it aesthetically pleasing, but how it works. It has to accomplish a particular purpose, and it's the interaction with the device that is critically important. And it's a process. So it's not a once off. And this is something that we see in user-centered design, and we really need to iterate. And this is really the principle of really human-computer interaction, HCI, where we are going to face individuals with capabilities that they can't interact. So you want to be able to have a system that that one can interact with irrespective of their capabilities, and that can be integrated in their routine life. As I mentioned here earlier, many studies are performed in community dwelling functional older adults, and the older adults are usually young, robust 65-year-old marathon runners. So we really need to think about what are the needs, what are the requirements, then design the specifications, implement, and then it's really this cycle. You kind of keep on going back. And this is what we call a systems engineering approach, where you're trying to maximize effectiveness and efficacy and satisfaction for a given specific concept. We talked a little bit about laboratory and field-based testing. Just want to kind of put that back out here because I think it's really important to say, and we all know this in our usual kind of research endeavors, that our laboratory testing really is controlled environment. You lose real world fidelity. It's much more affordable, and it allows you to rapidly iterate, rapid cycling. Versus the field-based, anything goes. You can't directly observe, so you don't really know what happens. And that becomes very difficult and very expensive as well. A lot of commercial health apps, for instance, do not have a considerable amount of field-based testing. So while it may work in the lab, it's not working in the field. And then you say, well, if it's not working in the field, then why deploy it? Specific to older adults, we know this. Their functional mobility impairments. They have reduced reaction time. And this really has to do with the ergonomics of a device or a system. Their perceptual abilities are compromised. They have poor eyesight. They have reduced scanning capabilities to look at a screen quickly. Their color perception, their contrast discrimination. These may sound like trivial things, but many apps are not designed with these in mind. Hearing impairment, memory challenges, ease of use. That, I think, in my mind, at least in my experience into conducting a lot of the usability studies that we conduct, if they can't use it easily, they're not going to use it. And so that's really an important predictor of future-based adherence. A one-size-fits-all approach doesn't work in technology, and really needs to be defined. What is the need? What is the user? And then you target accordingly. These are a couple of caveats that I've kind of learned over time. Try not to have a system that is busy. Try not to have multiple screens. Let individuals have a good bit of time to explore and use the app, and try not to multitask. So, for instance, here, it's great, if you have a video, It's good to have subtitles. So that was done deliberately. Why? You want to try to avoid rapid change of screen. You want to avoid small fonts, serif fonts, fancy fonts. Put it in big letters. Avoid blue. And the reason for that is it has to do with contrast sensitivity. We all know that all mobile devices have accessibility features. Put the brightness, make sure the brightness is maximized in any type of app-based. Again, the brighter it is, and let the user, reduce that. Try to have differences between your colors. I think that's also an important caveat. And these are some of the granular design features, and spacing, of course. I put this here because you want to be able to do a prototype, and part of the prototype is the brainstorming, and you do what we call you do whiteboarding and wireframes. It's termed wireframes, and this is part of the usability assessment, the brainstorming, where you can get your users to come in and help you design it, what's helpful for them, and always involve the end user. And this is what we call prototyping, where you really draw it out, and then you get input on that from the end user. Now, this is something that often bugs me, and in the sense that when we think about usability studies, we always want to kind of think about how many do you need to be able to ensure that you have a product that actually we find the problems and we can improve it. What's kind of like the diminishing returns? So most usability studies, the basic premise is really to rely predominantly on qualitative inquiry and theoretical saturation. In this study, this is a seminal study by Faulkner that really demonstrated that if you look here, you have 20 users, you'll find approximately 98.4% of all problems. So you probably need a little less than that. Nielsen actually came up with another number of between 5 and 10. I actually just recently reread that article. The challenge here is you need to be very clear. Are you looking at statistical significance between your measures, pre-post, for instance, between groups, or are you trying to improve the product qualitatively? Very big differences, and that needs to be kind of kept in when you're thinking about grant proposals and the like. I can tell you that because I just got burned on one because I wasn't clear on that, and the reviewer, nabbed me on that. So when we think about user-centered design, and when we think about, conducting such user-based assessments, we need to think about what is the task. You provide the instructions, they provide feedback on the process, and we always videotape everything and then kind of look at it afterwards in our studies, and then see where can we improve upon a given system. Any type of technology requires hardware and/or application. You do the field-based usability. In our situation with our system, we were going to do a pilot resistance-based program, and I'll show you some of the data on that. And then our hope is ultimately for those with sarcopenia or frailty that we can engage them in a resistance-based home exercise program. So this is a device that we created a number of years ago as part of a student of ours at Dartmouth. That started from her senior thesis, which consisted of a resistant exercise band and a sensor. There was an electrical component as well. There was a remote monitoring device and a Bluetooth-enabled component as well. It was very primitive, and I want you to see this in under figure A. It was clunky. I would need two hands. It was so big, the device, that there was no way when we tested it with individuals, they were like, I'm never going to use this. But what we found is that we found repeatability. And I think in any type of prototype, this is where you got to start somewhere. And often you start off with a product that is really not pretty, not aesthetically pleasing, huge what we call form factor, which is large. And it's not similar to, for instance, like a little iPod, AirPod case that you can carry in your pocket. So we asked in this small initial study, we actually had individuals conduct 4 different types of exercises as observed above. And then we looked at minimum and maximal peaks and looking at the relative force that was generated. And what we found was relatively good consistency. So we then conducted some usability testing with this device, both in the lab and then in the home-based setting. And what we we engaged in the think aloud technique, which is really having individuals use the device, videotape them, and then we were asking probing questions. We created an app. And as you can see here, there were a variety of different cycles. First, we talked to the end users, and we actually had videotaped a student doing an exercise. And then we had older adults view this and then conduct a system usability scale questionnaire. Then we did some interviewing of older adults using black and white wireframes. And then we created an app. And this was some pilot funding that I had received a couple of years back. And we have a really nice app at this stage, which actually allows us to identify what exercise you're doing, your Borg perceived exertional scale, the number of repetitions, and then you can assess and complete how hard was it based on the Borg scale. And this is, again, some other schematics there. We then did a small pilot study that demonstrated really a decent system usability scale score of 66. For just to put it into context, a score of 67 or above is really thought to be acceptable in the usability sphere. We actually did some sentiment analysis using some natural language processing, and really found that generally overall our older adults felt that this was potentially of use. So what did we do? We actually we ended up doing a real world usability study, and this actually all this data actually allowed us to submit a phase 1 STTR, so small business technology transfer grant, which this is part of the results here, that we were able to do a 4-week usability study and actually found improved patient adherence. Sorry, that was a typo there. System usability scale that was high. Folks were confident in using the system, and that they would actually pay for using the system. So all this data actually led to just thinking about some outcomes. We actually published a whole slew of papers here, got 2 patents, and this formative data actually we were very pleased. We just got funded on a phase 2 STTR, a $1.8 million phase 2 STTR, where we're going to be conducting a number of usability studies in a home-based clinical trial here at UNC in the next few years. So I'm showing this. I wanted to show this as more of a test use case of how we were able to design some technology, and it actually came out of my K23 award, unexpectedly, really, but it actually opened up another line of research that I'm working collaboratively with the small business, and we're able to conduct this here at UNC, and it's been a lot of fun. And learning a little bit about the business aspect, which I was absolutely clueless about. And as I always like to say, currently making a negative amount on this at this stage. But who knows? I like the science. I like the ability to kind of create this, and it's really come a long way. And with that, just countless many thanks to everybody here over the last 3 years since I've been here at UNC, and it's been a great transition, and hopefully many more years to come. And really want to thank everybody for their time and attention today, and probably a little bit of an unconventional presentation.
All right, that was great.
And I'm happy to take questions, Penny.
Yeah, thank you, John. That was a lot. Very impressive. Questions?
Question, John.
Yeah.
One thing I think you're right. When you look at your stats of the people who are less than 65, like 10 years ago, now those people are over 65. So you just would anticipate that it's going to get more and more where people are technology fine. What I find, the question I have is about telehealth. At what point and where do things happen where you would go ahead and bring a partner in to the telehealth stuff? Because often somebody's quite facile with it, but then if they get dementia, they can't. We've moved now where everything's in my chart and all of those things, but they may not be getting their pings. And if it's not set up that a partner or a caregiver, child, spouse, somebody is also getting pinged, you're going to lose some of the healthcare things. And it's, we have all of this about being privacy and a person's own thing, but that's the one tricky point is, because it's not so easy to get on somebody else's my chart.
So you're absolutely right. And I'm glad you brought that. And actually, in hindsight, I probably should have talked a little bit about technology competency within this. So this is, I always love when you give talks like this, because it says, oh, I should have talked about that. I should have talked about that. So let me address this in a couple of multi-prong here. First, one thing that we're not doing in clinical care, which, and this goes to the same thing in research, is we need to be able to evaluate technology competency. And depending on one's technology competence, then that will really predict, are they going to, in part, are they going to engage in the intervention? Are they going to engage in their healthcare and the like? If they can't turn their smartphone on or otherwise, then you got a problem. And that's where I think you have to have your partner, your care partner, to be able to help support them. I will share with you.
But it's that time of, you need to assess this routinely, because somebody can be fine and then 2 years later they can't do it.
Absolutely. And sorry, my bandwidth was going as I forewarned Kelly that I was trying to be outside here. So here, back inside. Okay. So you're absolutely right. And I think this, in my mind, we should be asking about this almost like on a yearly basis, almost like as part of your annual wellness visit or annual physical, to say, and there are really short scales, technology competence or computer proficiency scales, 6 questions. Doesn't sound like a lot, or even like some shorter screeners to be able to assess for that. I really appreciated your point when you mentioned about caregivers and almost like caregiver dyads. We have a grant that I have currently, on the cusp, so to speak, has to do with that, where we're having, individuals with dementia, patients with dementia, or early on dementia and health promotion intervention using telemedicine, but we deliberately included the caregiver as part of the intervention as a dyad, because in part, patients with dementia obviously have other challenges, but when you have that dyad, that really strengthens the ability, for any technology mismatch with or without dementia. And we did that with our obesity pilots, and are doing that with our R01. We're strongly encouraging our caregiver partner.
I found it interesting how much it costs to develop an app. We, in the Action Alliance, you know, we have this portal and it is mobile friendly, but we don't have a specific app. And frequently people say, well, are you going to develop an app? Have you developed an app? And I don't think we had 270K as our, I mean, we knew it was out of our budget, but that was an interesting number to see.
Yeah, you know, and it all depends on the capabilities that you want and functionality and what data you're going to get from the back end and the like. But they do cost a lot, and you know, developer time is a lot more expensive nowadays than it was even like 5 or 10 years ago. It's a hot commodity.
Yeah, well, when Develop remained in the game, I think it was around 65K, but
yeah,
it was already developed, and Kirsten's just talking something about yeah, but we were I think they, you know, we were working with academics to a degree with it.
Other questions? Got a few minutes. I see a couple comments, but no other questions in the chat. Okay, well, maybe we'll give people a few minutes to transition between meetings, including John, who may need to rejigger where he is for his internet access. I appreciate your efforts to get yourself some time in the out of doors, though.
Yeah. Well, I really appreciate everybody's attention and invitation, as always. Really, you know, thank you for including me in your group, and anyone who has any inkling or thoughts on anything technology based in older adults, happy to weigh in at any time. This is like this is like not that the other stuff's not the fun part, but this is like really fun in my mind.
Well, we definitely appreciate your expertise and experience from this. I mean, you've clearly delved in deep, so we're glad to learn from your experiences.
Great.
Okay, well, we will end there, and thanks everybody.
I'm gonna go ahead and stop the recording, and then I'll just launch the exit poll for everybody on their way out.
Oh yes, thank you. Thanks again.